of all, I just wanted to welcome you to the village. Carquinez Village is a virtual village that is an organization between Benicia and Vallejo that allows older adults and to connect, support, and inspire each other as we age. It's not a building or a place, but a virtual organization that offers a range of support services in need, such and plus stimulating, we hope stimulating activities to engage the community and the members' minds. Our goal is to assist seniors to live in the place that they call home with meaning and peace of mind as part of the vibrant older community. So this morning, we would certainly like to welcome Dr. Catherine Conde, who is the founder of Northern California NeuroHealth and is a licensed clinical psychologist with specialty training in neuropsychology. She got her training, first of all, with an undergraduate degree and her master's degree at the University of San Francisco, and then received her doctorate through, let's see, was that Loma Linda University School of Medicine. She's completed a two-year clinical neuropsychology postdoctoral program at UC Davis on Alzheimer's disease. And she's conducted numerous clinical neuropsychological evaluations for patients with dementia. And so now she has her private practice in Vacaville, where she offers neuropsychological evaluations, immigration psychological evaluations, and therapy. So we'd like to welcome her. With that, I'll let you take over, Dr. Conde.
Wonderful. Thank you so much. And thank you for having me this morning. I'm very excited to be here presenting with you guys. So today I will be talking about steps towards a healthy brain. And before I get into that, I just want to talk to you guys a little bit more about me, about what I do. That way you can get a better understanding of why I'm so passionate about this work. So like Linda mentioned, I am a neuropsychologist, and every time I introduce myself as a neuropsychologist, everyone's like, what does that mean? What do you mean a neuropsychologist? That's the first time I'm hearing that. And, you know, they have a good point, because neuropsychology is very much a subspecialty. And so there aren't that many neuropsychologists out there. And so for me, I am first and foremost a licensed clinical psychologist. And after that, I got specialty training in neuropsychology, which is a training that allows me to understand the relationship between the brain and behavior. And so for that, that's when I went to the UC Davis Alzheimer's Disease Center, and I was there for 2 years after I received my doctorate to get specialty training. And even throughout my doctorate, I was getting additional training on how to conduct neuropsychological evaluations. So I really enjoy working with older adults and being able to give them the tools that they need to understand what's going on with their brain and how they can improve their memory. So with that, I'm going to go ahead and share my screen. And if you guys have questions along the way, feel free to stop me and ask. There's also going to be time at the end for questions, okay? All righty. Can you guys see my screen okay?
Yes.
All right, wonderful. So today our talk is going to be steps towards a healthy brain. And this is just an overview of what we are going to be talking about. So first, I'm going to go over what normal cognitive aging is. Then we're going to talk about mild cognitive impairment, about dementia, about neuropsychological evaluations, and then we're going to talk a little bit more about the different types of dementias and things that we can do to keep our brain healthy. And then we're going to leave room for questions. All right. So to get started, I want you to think of your brain as a bank account. And so everything that you put in your brain are things that you're gonna do to have a savings account. And so I want you to think of your memory as your savings account. So you're putting money in as you grow and as you're aging to try to improve your memory. And so this could be made up of like level of education, like how far you get in school. It could be career achievements, and it could be different like talents that you learn, whether it's to play an instrument and different things. So these are things that you're adding to your brain to keep your health and keep your brain healthy. there's actually a term for that, and that's called cognitive reserve. And it's made up of the different activities and the different things that we dedicate time to, because all these things actually do help us learn and keep our brain strong, because we need to think of our brain as like a muscle. The more we work it out, the stronger it gets. And so there has been research that shows that all these factors are supposed to be related to slowing the onset of Alzheimer's disease. So our cognitive reserve, our little piggy bank that we have, like the more that we have in it, the greater and the more our brain is protected. And so engaging in different life activities is something that we can do in order to help our brain stay healthy. So once again, so when we think of our brain as a healthy piggy bank, we're going to think of this as having no cognitive impairment. So this is like, let's say if 100 was the max amount that you can have in your bank account. When you have no cognitive impairment and your brain is healthy, you're at 100. So you have the money to buy everything you need. You're functioning independently. You have very few complaints about things, and no one basically has noticed any changes in your functioning. You're functioning great. So that's no cognitive impairment. So then we're going to talk a little bit more about what normal cognitive aging looks like, because it's true. As we get older, we are going to age. And so this is something that happens that is intrinsic and something that happens to everyone. It's something that's universal, that we're all going to age. And when we think about some of the physical changes that come with aging, we are able to see this, when we look in the mirror, whether it's wrinkling of the skin, graying of our hair. We might feel a little weaker here and there, or our bone might decrease in mass. And so these are the different physical changes that we see outside. But when looking at our brain, we also have to be thinking that our brain is also going through these same changes, that our brain is also slowing down. And these changes can actually occur at different rates for different individuals. So just know that not everyone's going to age the same. And so with normal cognitive aging, it's not all bad. There are some things that actually do improve with age, and that is like our verbal ability and also some of our knowledge. And because, as we age, we also get wiser. And so these are some of the things that do improve. However, there are some things that will decrease with age. And so for that, we're going to think about like our processing speed, and that's how fast, we're able to answer a question or solve a problem. And also our ability to manipulate information is going to decline with age. And so these are the things that we have to keep in mind. And so like, what does that look like when we're thinking of like day-to-day things? And the first one, it could be like losing our train of thought. Like if we're talking to someone and say, oh, I was talking about this, but I forgot what I was talking about. Or the tip of the tongue phenomenon. And this is like, for example, if you went to dinner with a friend and, let's say like if you're thinking about a restaurant and you're like, I can't remember the name of the restaurant. I know it, but I can't think of it. And so that's what we think about when we think of the tip of the tongue phenomena. And also we're going to experience difficulty remembering new information. And so these are things that happen to everyone. They even happen to me often. And so this is okay. I don't want you guys to worry if you're experiencing this, because like I said, with age, there are some things that do happen, and these are some of them. And so these are things that are kind of just inevitable that will happen, but we just need to make sure that they don't start interfering with our day-to-day life. Okay, because when they do start interfering with our day-to-day life, that is when we're going to see a problem. Now I'm going to talk a little bit about mild cognitive impairment. Okay, and so this is a stage between normal cognitive changes and dementia. It's like right in the middle. So like, it's not quite what you would consider normal, but it's not as far as dementia. And so we're thinking of our piggy bank again. It's not at 100, it's not at 0, but it's somewhere in between where you're starting to notice some of these changes, right? And so some of the problems that you could experience when having mild cognitive impairment include mild memory loss, difficulty planning, difficulty organizing things, forgetting names, forgetting conversations. And so these are things that we start noticing, and that you're going to see that families and friends might start noticing it as well. And this, when you have mild cognitive impairment, it does not necessarily mean that it's going to progress to dementia. Someone can have symptoms of mild cognitive impairment that are stable for several years and actually even improve over time. But it is something when we need to start paying a little more attention. So, thinking of our piggy bank, it's less than what we had before, but it's not at a super low. But we need to start protecting our piggy bank so it doesn't keep decreasing. And we need to think about ways to protect our piggy bank. And so, like, if a thief is stealing money, that's going to deplete the accounts. And with what I call thieves, I'm talking about other diseases that we might have, like diabetes or cholesterol. And these are things that also take a toll in our brain. So we need to think about really protecting our brain, okay? And then here we are with dementia. And this is when our piggy bank is at a very depleted amount, that we don't have enough for our everyday needs, right? Our piggy bank is on E, and it's, we're not very happy when we have not enough money and not enough savings in our account. And so it's important to get help when we're here, because this is when we actually do start experiencing changes, and we need help from caregivers or family members to help us get by. Okay. Any questions so far? No? Okay. And if questions come up in the chat box, feel free to put them there, and someone, could just let me know that if we have questions there, because I don't see them pop up right here. But feel free to ask away if you guys have questions. All right, so let's talk a little bit more about what dementia is. And so dementia is a loss of cognitive function, which is basically our ability to think, remember, or reason. And it impacts us to an extent that it interferes with our daily activities and our daily life. And so the changes that we might see with dementia include problems with our memory. We might experience difficulty with speaking and communicating. We might have problems with our visual perceptions, difficulty problem solving, and having the ability to manage our day-to-day tasks, and also difficulty paying attention. Okay, and some people with dementia cannot control their emotions, and sometimes we do see changes with their personalities as well. So this is a nice little umbrella. When people ask me, what's the difference between dementia and Alzheimer's? That's a question that I get almost every day. And I really like this nice term that helps us understand it a little bit more. So we can think of dementia as like the overall umbrella term for loss of memory, right? It's more of like that symptom. And then when we can think about what causes the dementia, we talk and we think about Alzheimer's disease, Lewy body dementia, there's vascular dementia, frontotemporal dementia, Parkinson's, Huntington's, or mixed dementia. So there are a lot of things that it can be. So let me see, I saw a question over here. Okay, perfect. Thank you, Susan. And so that's what we're trying to understand. We're trying to understand what type of dementia it is. And so another really nice kind of analogy that I have is someone on a wheelchair, right? So I want to walk you guys through this. So if someone is wheelchair bound or is unable to walk, that is the symptom that they're experiencing, like inability to walk. And then my job as a neuropsychologist would be understanding the reason why. So if someone's unable to walk, it could be because they have a broken leg. It could be because they have multiple sclerosis, a spinal cord injury, they just fainted and they need additional support, or they just gave birth. There are many, many different options, or even osteoporosis and they have difficulty walking. There are many reasons why someone might be unable to walk. So the same thing with dementia. Someone's having loss of memory or difficulty with memory problems. That is dementia. That's the definition of dementia. But once again, my job as a neuropsychologist is to figure out what kind of dementia they have. And so, it could be Alzheimer's disease. It could be frontotemporal dementia. It could be vascular dementia. It could be Lewy body dementia. Or it could be mixed dementia. So that's how I approach it when I look at my patient, trying to understand what is the cause, okay? And so that's when we're going to talk a little bit more about neuropsychological evaluations. And these are the types of evaluations that I do with my patient. And it's not like a quick doctor's appointment where you go in and out, kind of tell me what's wrong, and then you leave. Most often, these appointments last between 3 to 4 hours. So if you come to see me for a day, we're going to get to know each other real well because we're going to be together for a long time. So the first thing that I do is I conduct a clinical interview. And if someone comes in and they have memory problems, I usually like them to bring either a family member or a friend that can often talk about the changes that they're experiencing. Because if someone has memory problems, they're not always going to remember all the problems that they have. So I start asking my patient and also the family member that they bring along. And so I ask about medical history. I ask about social history, and I look at any brain scans. And I kind of want to go into these a little bit more because with medical history, I like to understand, if they had any head injuries, when these problems started, how they're affecting them. I want to see if they're taking any other kind of medication because sometimes certain medications could impact our functioning and our ability to think. So for example, if someone's taking medication because they have, they're urinating a lot and, they have incontinence. And so sometimes those medications actually do affect memory. And so if I see that, I have them talk to their doctor about maybe thinking of an alternative medication or outweighing the pros and cons with their primary care provider. The other thing with social history, I try to see their level of functioning. If I see that they were a CEO at a top company and now they have problems, remembering if they had lunch or if they took out the laundry, that's something that's also very indicative of their previous functioning and now how they're doing. And so I also look at the brain scans. And then after that, I do cognitive testing. And this is when I'm kind of just what's depicted on this picture, where I'm sitting with the patient and I assess their memory, their language, their attention, their processing speed. And I look at all these different things, but I really go in depth to try to understand what's happening. So for example, with memory testing, I assess both visual and verbal memory. And so if someone has problems with remembering something that's said verbally, we look at I would give them a list of words. I would say, remember these 10 words: cat, dog, pencil, mirror. I don't know, right? A list of words. And then 30 minutes later, I ask them to tell me those words again. And I'm going to see how well they retained it. And I also test their visual memory. So for example, I show them a picture, oh, look at this abstract picture, draw it. And then 30 minutes later, I ask them to once again draw that from memory. And so I'm assessing both visual and verbal memory. And I kind of go in depth with all of those. And another thing I really like to talk about is mood, because sometimes people that have depression often feel like they also have memory problems, but it's important to tease it apart to see whether it's just depression or if there's really a memory problem. And if it's just a mood problem, it's good because we could also find a way to treat that. So that's what goes into my neuropsychological evaluation. after I meet with the patient, I write a report that's approximately like 10 pages, and that kind of goes over all of the findings that we had and recommendations. And that's something that I can send to the doctor. But I also have a feedback session with my patients where I ask them to come with family members, and at that time we go over any diagnosis. Okay. All right. And so after I do my test, this is like when I feel like a scientist and I'm over here trying to tease all these tests apart, and I'm trying to determine, okay, what does this person have? And it's not just looking at a score, but we look at different norms. And so like the score that you would get, I would compare to other individuals your same age and education level to see how you're doing compared to your peers. And certain dementias have certain profiles. So that's what I'm going to be looking at. So now let's go a little bit more and talk about each of the dementias. Okay, so we are going to talk about Alzheimer's disease. And so this is the most common cause of dementia in older adults. And I'm sure you guys have heard of plaques and tangles with Alzheimer's. And so I kind of want to explain those a little bit more. So the plaques that you see right here are these amyloid plaques that build. I have two pictures. The first one is A, the second one is B. A is normal, and then B is what it would look like with Alzheimer's disease. And so here are the plaques that form and the tangles inside of this. And so that's kind of what's happening inside of the nerve cell. All right. And so I want you to see this picture of a healthy brain versus a brain of someone with Alzheimer's disease. And so this is also what we look at. And, you know, when thinking about Alzheimer's disease, the initial damage occurs in the hippocampus. And so this is the area of our brain that's in charge of memory and learning and storing our memories. And so that's where the damage initially appears. And that's, you know, what we can see. And then after that, it progresses and it kind of spreads through the brain tissue and ends up causing significant shrinkage. And so, you know, this is a little scary to see because we see a healthy brain and then also the brain of someone with Alzheimer's disease. I have another picture here. This is a brain autopsy in advanced Alzheimer's disease. In the normal brain, we see it's all plump and it looks really good. It looks full. This slice here looks really good. But then when we look at the one of someone with Alzheimer's disease, we see that it's like shrunk, right? It looks, does not look healthy. And so once we slice it, we're able to see that, you know, it has this atrophy all over. And so that's what's causing all of our memory problems as well. Okay. And with Alzheimer's disease, damage to the brain actually starts a decade or more before we start seeing the memory problems. And so when we actually start seeing the problems, it's when we look at the brain, we actually are able to see these changes. And so some problems with Alzheimer's can include getting lost, trouble handling, you know, your bills and your payments to the point where you need someone to step in and really help out. Okay. Any questions with Alzheimer's disease? Okay. Is the diagnosis of Alzheimer's disease still only on autopsy? So that is a question that was asked. And so with that, that's like the only certain way to diagnosis. But if you come and you have a neuropsychological evaluation, we can diagnose someone with like probable Alzheimer's disease. And this is because we look at the tests and we have the data that gives us like a certain profile of what someone with Alzheimer's looks like. And this is what, you know, the years of research and data has showed us. So like if you come for a neuropsychological evaluation, you can get that diagnosis because we're really going to try to understand kind of like what that looks like. And so like if someone comes to my office and someone with Alzheimer's disease mostly has problems with like memory and language. And so that's the areas that I'm going to be looking for as well. Okay. So now we're going to be talking about this other type of dementia, and this is called Lewy body dementia. And this typically begins after the age of 50, but can occur earlier. And so it involves abnormal protein deposits that are called Lewy bodies. And they actually look like little balloons. And you can see over here that these are the little balloon-like structures that form. And so that's kind of what is being formed inside the nerve cell. And there are actually two types, two related conditions, right? And the first one is dementia with Lewy bodies. And the second one is Parkinson's disease dementia. And so dementia with Lewy bodies, and so these are, when someone has dementia with Lewy bodies, they have difficulty sleeping, they have loss of smell, sometimes they have visual hallucinations, and they also have movement problems. However, the thing with dementia with Lewy bodies is that the movement, so I kind of want to differentiate the two. Let's talk about Parkinson's disease. And so with Parkinson's disease, I'm sure you've seen people that with Parkinson's disease that have like all these movement disorders as well. And so that's kind of like what we're looking at with someone with Lewy bodies. So we're going to look at the movement problems. And with Parkinson's, the movement problems start before the memory problems. And with dementia with Lewy bodies, usually the memory problems and all the cognitive changes happen before the movement. So with this one, we can see here, precedes movement by as many as 10 years, and then the cognitive symptoms for Parkinson's develop more than a year after the movement problems begin, okay? So kind of like that's the way that we can tease those two apart. So now we're going to talk a little bit about vascular dementia. And vascular dementia is more of a general term that's used to describe some of the damage that's caused to the brain related to the blood flow that's going to the brain. And so kind of with like real estate, you know, we hear people talk about real estate. It's all about location, location, location. The same thing happens with vascular dementia because it's all about location, location, location. So like if you have a stroke and then it's in a very crucial area of your brain, that could really, really affect you. However, you know, if it's an area that, you know, does not have as much weight, then the damage could be less. And so vascular dementia could result from strokes or other conditions that do affect the level of oxygen that your brain is receiving. Okay. And then we're going to talk a little bit about frontotemporal dementia. And so this is actually something that happens at a younger age for someone that's younger. And as we see here in this picture, these are like the frontal lobes and the temporal lobe. And so that's where we see like the shrinkage with the frontotemporal dementia. It's not necessarily the entire brain that shrinks, it's more the front side that shrinks. And so with people with frontotemporal dementia, they have a lot of changes in their personality. It's kind of like they have a loss of filter. And you know, this is why when we talk about kids and, you know, like the frontal lobes aren't fully developed till like a certain age. And that's, you know, when they get the ability to reason and think more clearly. So kind of like the opposite happens. It's like, you know, we're kind of losing that filter, that frontal lobe that allows us the ability to reason and to think a little bit more. And so you might hear people refer to this as Pick's disease because a while back, it was Dr. Arnold Pick who first diagnosed and described a patient that had this. And so that's why it was initially described as Pick's disease. And the patient was having difficulty with language. And so here we also see problems with language. And then there are two main types of this syndrome. And the first one is the behavioral variant of frontotemporal dementia. And this is the one that includes like the behavioral changes that I was talking about. And there's also primary progressive aphasia, which includes changes in the ability to speak and to reason. And so these are the things that we start to see with primary progressive aphasia. Okay. All right, so now I have a little poll here. Maybe Susan can help me launch this poll. And I just want to get a sense of if anyone has friends or relatives that you think have dementia or memory problems. And if you can just answer the first one, I know we have 2 questions listed on there, but seeing if you can answer the first one. Do you have friends and or relatives who have dementia or memory problems? And the options are yes, no, or I'm not sure.
The submit button isn't working.
Oh, it's not? Well, it might have you choose something from the bottom one. So if you just want to choose a random one from there, and then we'll go that one. I know that sometimes happens. Does that work? Okay, perfect. Thank you.
So only 3 people have voted. 4 people, 5 people. Anybody else? All right. So we have, I'm going to end the poll.
60% of you guys indicated yes, that's you believe that someone that you know might have problems with memory, and then 40 of you guys reported no, and that's a big number, so that's good. So let's talk about, you know, what happens when someone might have these problems. Okay, so thank you so much for voting. All right, so oftentimes, like, you know, I get people that ask me the question, and I'm gonna, oops, let me see. I'm gonna go ahead and stop sharing this because I want to see your faces and I want to engage with you guys a little bit more. So oftentimes I do have people that ask me like, okay, I have a friend or I have a relative who I think might have a memory problem. What do I do? How do I tell them I don't want to hurt their feelings? Have any of you guys like had these questions come or come to mind? Yeah. All right. So usually what I tell my patients or my friends that ask these questions is that I tell them like, you know, just think of it as that you're approaching it from like a caring point of view. It's not like you're trying to challenge their thinking abilities. It's more of you just wanting to support them. So I give them the example, like if I had a friend who had these memory problems, what I would do is like, you know, I would go up to them and say like, or like, hey, Bob, you know, like, I've noticed that like, you know, you're asking me the same questions and sometimes like, you know, I tell you to do things and then you ask me these questions again. And you could even say like, you know, I attended this talk and they were talking about memory problems. And one of the things that you can do is take a neuropsychological evaluation. And this is a test that you can do to help you see how your brain is functioning. And then Bob's like, well, I don't think I have memory problems. And then you could say, well, that's fine. And you could say like, you know, well, let's go take the test. You know, you might be absolutely perfect. And if that's the case, then great, you're going to prove me wrong. But if not, then, you know, there's some things that I'm sure they can support you in different ways. And so kind of just pose it as that way that if you go get a neuropsychological evaluation, you're not always going to come out with a diagnosis. You know, there are some times that you're going to get a result that might be fine, that might be normal, or it might be mood symptoms. And so there are different ways that we're going to be able to treat that. And, you know, you could even tell your friend like, oh, I'll go too, like, I'll go get my memory tested. Let's see, you know, how we do compare to each other and kind of just like lighten up the mood like that and support them, because there is still a stigma around mental health and also around these cognitive problems. So we just want to make sure that everyone feels supported. Okay. Any other questions there or anything you guys want to share? No? Okay, so I'm going to share my screen again. All right. So since we were referring to our brain as our brain piggy bank, now I want to see what we can talk about to protect that piggy bank, right? So that way our funds don't get depleted. So But before that, I want to talk about certain risk factors for dementia, because there are certain things that do put us at greater risk. And it's important for us to know what these things are so that we can protect ourselves from them. So the first one is age. And that's just a given that the older we get, the greater risk we have of getting dementia. The other thing is hypertension. If we have hypertension, we're at a greater risk. Same thing with strokes. And also with drinking alcohol and diabetes. And also Down syndrome. And many people with Down syndrome actually develop symptoms of Alzheimer's by the time they reach middle age. And so that's actually something that does affect that population more. And then also with genetics. With genetics, there's a greater chance of developing dementia if you have one of the family members that does have a disorder. So also kind of thinking about what you can do if there is someone in your family that has that. Injuries and also smoking, that does put us at greater risk. Okay. And then we are going to talk about modifiable risk factors. And these are the things that are risk, but we want to be able to know what they are so that way we can modify them. Okay. So here we go. And so these are the things, this is a nice little picture from the Lancet Commission. And these are the things that we can do that actually end up protecting our brain. So as we see here, there are certain things that we are able to modify potentially in our life that can help us protect from dementia. And the first one is education. So having greater education actually helps. But if you have less education, that does put you at a greater risk for dementia. The other thing that we have here is hearing loss. And so if we think about someone that has hearing loss, they become more socially isolated. Sometimes they're not getting the cognitive stimulation that their brain needs. And so these are things that, you know, really do impact us. So with hearing loss, a good thing that you could do is like hearing centers. I've been collaborating a lot with them. And so these are the things that we can actually do. So, right, getting a hearing aid, you know, if you consume alcohol, making sure that you don't drink more than 21 units a week. If you have difficulties with obesity, finding ways that you can work on the different ways that you can control your weight and different exercises that you can do to try to modify that. Also with smoking, you know, cutting down on smoking or seeing if there's a smoking support group that you could join. With depression, making sure that you get the support from mental health providers. And, you know, air pollution is also one of the things that's on here. So these are the different things that we can do to try to improve what we're doing. Okay. And so once again, like, how can I improve my memory? And there's this really nice little acronym that kind of just came out that's talking about the things that you can do. And this is an easy way to remember it. And it's actually called dancers. And so each letter stands for something. So like the first one, D stands for disease management. A stands for physical activity. N for nutrition. C for cognitive stimulation. E for engagement with others. R for relaxation, and that's more for like stress management. And then the S is for sleep hygiene. So we're going to talk about these a little bit more just in depth to see what we can actually do to keep our brains healthy. Okay. But this is a nice little way to try to remember. If a friend asks you like, what can I do to like help my memory? Just think of dancers, and then hopefully the words are going to come for each of those letters. All right. So first one here, we have disease management. And this is just a quick little picture that I want to share that helps us remember this a little bit more. And so the first one is disease management. And it says, take care of your body because it's the only place you have to live in. That's a great point. And so this means controlling our diabetes, controlling our hypertension, and different things that we can do to just protect our body, like making sure that we take the medication that we need at the time that we need it, okay? Next thing that we have here is physical activity. And I think this is also a great little picture that just really summarizes it all. And this is, if any single pill carried the scope of benefits that physical exercise brings, it would be considered a miracle drug. And this is so true, because whatever we do that's good for our heart is good for our brain. And we just need to think about ways that we can kind of keep all of that healthy, and the best way to do it is through physical activity. The next thing here is actually the Mediterranean diet, and I'm pretty sure you guys must have heard of it. And this is a diet that's rich in fruits and vegetables and olive oils and whole grains. And so there, it does have lots of benefits. And studies have shown that people who closely follow a Mediterranean diet are less likely to have Alzheimer's disease than the people who don't follow that diet. And the research also shows that this specific diet helps slow cognitive decline in older adults. And so when we're thinking about how we can eat healthy, kind of just also thinking about what we put into our body, and even thinking about it as that piggy bank again. Remember, we need to put healthy stuff, and we need to put good things into our body to keep it healthy and to keep it working. All right. So now we are going to talk about cognitive stimulation. And so these are things that we can actually do to keep our brain active and working, because we don't just want to exercise our physical body, we want to exercise our muscles as well. Okay. And so these are actually some of the things that we can do. And so it's like playing games of skills, like doing crossword puzzles, playing music. These are like attending different courses. These are things that we can do to keep our mind working. And so the key ingredient in all these is learning new exercise and just doing things that keep us engaged. And there's actually this really interesting study that came out in 2008, and it shows that high level of complex mental activities across the lifespan was correlated with reduced hippocampal atrophy. And so, like I mentioned before, the hippocampus is that thing that's circled in red. And so that's the area of our brain that's responsible like for memory and learning. And with Alzheimer's disease, that's the first thing that starts shrinking. And so this study was pretty impressive, because it found that when we have these cognitive engagements, like we were saying, there's a reduced rate of atrophy. So it could also protect us from potentially developing Alzheimer's disease. There's also this other study that was published in 2012 that was looking at in 79. And they actually found that greater variety of participation in activities, regardless of the cognitive challenge, was associated with 11 to 18% reduction in risk of cognitive impairment. So it's not just about, doing crossword puzzles every day. It's more about variety. It's doing crossword puzzles, learning a new language, taking a new class. It's more about this variability and more about the ability to get your brain moving and thinking and challenging your brain. All right, and this next one, which I'm sure you guys are more familiar than me with, is engagement with others. And I'm sure being part of this village is something that has helped a lot, because especially with COVID and all these isolations that we were faced with, it must have been nice having this virtual support group to connect with. So I'm very happy to see that there's a community out there that provides this social support for older adults. With social support, which is what you're getting from here, we're able to see that individuals that receive social support have lower blood pressure. They also have reduced mortality rates and also have higher cognitive function. So these are all wonderful things that you guys are getting out of this. And then hold on, let me see. I think I did see a question come through. All right. Cognitive engagement, learning something new is most beneficial. Okay, great. Thank you. Let's see. Talking a little bit more about social ties and participation. So social ties means having, a spouse, being connected to a larger group. And so we're able to see that having these connections actually do help us with certain things, not just kind of like that social connection. Like there was a study that was published in 2001 that showed that with each additional social tie, the risk of dementia decreased by 16%, whether that's, kind of having these group memberships like we were talking about. And with each additional productive activity, the risk for dementia decreased by 72%. And productive activity means volunteer work, paid work, helping someone else with daily tasks. And so it's once again about getting out there and doing things and having these social connections. There was also this Macarthur study of successful aging that found that participants that were receiving emotional support had greater baseline performance, and that even after a 7.5-year follow-up, they had better cognitive functioning. So this once again validates the importance of having a social environment and having this support. And it's something that actually ends up protecting older adults from cognitive age and supported, which is wonderful. Another thing that I want to talk about here is relaxation. And so having a stress-free zone, and this is basically just learning how to manage our mental health. And these are just some statistics that I want to bring up about mental health in older adults. And so this is a study adults that are males have anxiety, while 22% of women have anxiety. And then with depression, although it varies by living situation, because remember we were talking about the social ties of like, and people have different living situations, but in the general population, about 15% of older adults are suffering from depression. And it's important to acknowledge that there is help for this, and we can get you guys connected with mental health services to help you feel supported. Talking a little bit about the impact of stress and aging. So lifetime exposure to stress can end up affecting our body a lot. And so we want to be able to know that we're going to reduce the stress, because studies have shown that it does affect us a lot. And so aging is a period during which individuals have the difference in cognitions and experience different life changes. And so we need to be able to make sure that everyone feels supported. A way to help with stress is meditation. And there have been several studies that have actually shown that engaging in meditation can help reduce this stress levels. And this is because it reduces cortisol, and it also reduces the vascular risk factors, and it also enhances the cognitive reserve that we were talking about. And so it's important to participate in regular meditation, because it could actually help slow the rate of atrophy, which we were talking about, which was the shrinkage, and specifically it helps it in the prefrontal cortex, which is that area lit up in orange. Okay. And then I did see two questions here. With COVID, are you seeing an increase in depression in older adults? And anxiety seems to be talked about a lot in the current research. Is there actually a higher prevalence or just being talked more about more? Okay, so I'll go ahead and answer those two questions. So with explain more just based on the patients that I'm seeing, and I am seeing a lot more patients that are coming in because of the changes that they're seeing because of COVID, right? This impacted all of our lives. And so with us not being able to either leave our house and having more isolation, this does cause an increase. And so with COVID, you know, we are seeing that. And then with having it talked more about in literature, we are seeing that, you know, with the reduction of stigma with anxiety, more people are getting access to these services. And also, you know, we are like, I just think that this year with COVID, that kind of like, you know, threw us all off because
Dr. Condi,
an
every
increase
so
of
often your
anxiety
voice
just in my private practice patients, that is something that I'm seeing. Okay, so
Dr.
it's
Condi.
important to find ways to reduce stress, whether that's through medication or doing meditation exercises, getting help through therapy. And so there are certain things that you guys can do to help with that. Okay. And so the last thing that was on here was sleep hygiene. And these are some things that we can do to help us try to sleep better. And the first one is basically just, you know, having a routine that you could do every day, whether that's waking up every day at the same time and going to bed every day at the same time. The next one is regular exercise. And this is kind of an exercise that's appropriate for your mobility level. So making sure you talk to your doctor and you don't do something that you're going to end up pulling a muscle, you know, just some safe kind of exercise. And also if you nap, just make sure to limit the number of the naps and make sure you're not napping all day, because that will make it really hard to go to bed. The next thing is avoiding alcohol and tobacco or any type of caffeine after lunch, because it will keep us up a little bit more at night and make sure we don't get that restful sleep that we need. Another thing that's listed on there is spending more time outside, and also just making sure we get that sunlight, and then limiting the liquids that we drink in the evening, because if we drink right before going to bed, there is a greater possibility that we're going to wake up at night and have to use the restroom. Just eating a light snack before bed, and also if you can't sleep, just making sure that you get up and, you know, go do something to tire yourself out instead of staying in bed. Another thing that I did want to talk about a little bit more is about sleep apnea. And this is like, you know, if someone snores, if you have someone that you know that snores, or you yourself snores, making sure that you talk to your doctor about getting a sleep study, because sometimes there's a possibility that when we snore and are gasping for air, our brain is not getting enough oxygen. And so that needs, and it could affect cognitive function. So if you do have sleep apnea, making sure that you wear your CPAP to sleep, and making sure that there are different things that you do. Okay. And then I think I did see a question come up. Let me see 1 second. Why naps between 10 and 2? So that's a great question. And so this is thinking about someone that like wakes up early, let's say wakes up at 7 a.m., you know, and then they go ahead and nap in the midday. So that's kind of considered our midday, because if you go to bed or take a nap, let's say at 4 or 5 o'clock, that could also just roll over that when you wake up, you don't have enough time to tire yourself out before you go to bed at 8 or 9, whatever time you go to sleep. So just making sure that you do that midday, so that way you have enough time during the day to, you know, do exercise, still get some sunlight outside and tire yourself out. Okay. Modifiable risk factors that we talked about again. And I'm going to go ahead and quiz you guys again. So do you guys remember what the D stands for? And just feel free to unmute yourself and scream it out if you remember.
Disease management.
Wonderful. Perfect. What about the A?
Activity.
Wonderful. Good job. What about the N?
Nutrition.
Excellent. Great job, guys. And the C?
Cognitive
and
stimulation.
Stimulation.
Got it. All right. You guys are ahead of this. All right. Next, the E.
Engage.
Exercise.
And the R?
Relaxation.
You got it. S.
Sleep management. Stress management. Oh,
Sleep.
sleep management.
Yep.
Sleep hygiene.
First one, sleep hygiene. Sleep management, it all counts the same. Yeah. And so I'm going to see if Susan can help me with that poll again. I want to bring that up. And this time we're going to ignore that first question. I mean, you still had to answer it to get to the second one, but I want you to think about, out of all these actionable steps, which ones are you willing to try? And like, which one are you hoping to prioritize out of the dancers? Which one are you hoping to target first?
Oh.
I couldn't get on page 2. I was on it before, but I can't get on it now.
Well,
What question was that? I'm sorry, I missed that.
You probably have to answer one first.
So you have to answer 1 and then 2.
All right, so now we have 2 people that have voted.
I did answer 1 before.
I know you
Now
have,
you have to answer it again.
Yeah, you have to answer.
I didn't set this up correctly. That's why.
Okay, can you bring it back for me?
You should be able to see it.
I don't.
Huh. Okay, so we have 3 people who voted. Anybody else?
I still don't have it.
Yeah, I think Kathy, if you hit submit, did you hit submit?
Before I did.
So when it came
All
up
right.
this time, did you hit submit?
No, not this time.
But you don't see it?
No.
Okay, so we're just going to go ahead and end that poll there. It seemed like a lot of people were voting for disease management, activity, and nutrition. So it seems like those are the top 3 for our group. So that's wonderful. All right, and then I just want to make sure, I know we talked about time to yourself and think about what are 3 things that you are willing to do to protect your brain. And I understand that we all live different lifestyles. And so the things that I listed here might not have been something that, fits for everyone. So I want you to take a moment and to reflect on your personal life and think, what are 3 actionable steps and 3 things that you can really do to help your brain and help you stay healthy and help you protect your brain. You don't have to list them, and I'm not going to ask you about them, but I just really want you to take this moment for yourself and write those out, and maybe, whether post it on your fridge or, put it on a little Post-it note next to your laptop. That way you can see those every day and remind yourself to go ahead and do that. Okay. All right. And so with that, I just want to leave you guys with my information. So I do have my private practice in Vacaville, and I do offer neuropsychological evaluations. In addition to that, I also offer therapy for anyone that might have depression, anxiety, or just going through a difficult period in life and just learning how to manage their stress. So that is something that I offer. I accept private pay patients as well as those that have Medicare, Optum, and Cigna. And so these are the insurance that I am currently taking, and I am hoping to get paneled with a few other insurance in the near future. So if you guys have any questions, feel free to send me an email, okay? And then I do want to leave room for questions if you guys have any questions that you want me to address. I'm going to go ahead and stop sharing my screen. That way I can see your guys' faces, okay?
Thank you, Dr. Condi. I do think there are some questions in the chat that might not have gotten answered.
Okay.
So if you want to start there. How young can frontotemporal strike?
Yeah, so frontotemporal dementia is also something that could start fairly sooner. So when we think about Alzheimer's, Alzheimer's starts at age 65. But with frontotemporal dementia, that tends to start sooner than that. So it could be the period before someone turns 65. So we see someone coming in that's younger than 65, regardless of the age, that's when we start thinking about these other things too. Okay.
And then what is the cause of PICS or frontotemporal?
Frontotemporal dementia. So for that, you know, I'm going to have to get back to you for the specific cause of that because I don't have it off the top of my head. But what ends up happening is that there is shrinkage on the frontal lobes. So the frontal lobes and the temporal lobes, that's what starts the shrinkage of that first. And so that is what we tend to see.
And then there's a question about head injury. Can you talk more about that relationship?
Yes. So if someone has a head injury, you know, they might also experience problems with memory and cognition. And sometimes it's what we were talking about, the area where the damage happens. And so that could be something that can affects it. But also, like, you know, if we see like football players or people that have multiple head injuries, that is also something that continues to affect us. And, you know, we got to think of our brain. It's like a little Jello ball. Like if you kind of keep shaking it and hitting it, like Jello falls apart, you know, and we're got to think about our brain like that too. And so if it kind of we're shaking it and it's falling apart, the areas that might have been working like they used to are not going to be working the same. And so for, you know, for a mild cognitive impairment or for dementia, there's even like a specific specifier that we can say like due to a traumatic brain injury. And then we could specify it that way, because if that's the only thing that the person has, you know, they have no cholesterol, no diabetes, they're young, and that's the only thing that happened, then that's when we could say that that was likely the cause of their memory problems.
There's one about diabetes interplay with dementia that is not vascular related.
Okay, who had that question, and can you help me understand it a little bit more? What can you?
Kathy on mute. Oops, now you've just.
I got it. Yes, my question was a lot of the difficulties that they relate to diabetes have to do with either high blood pressure or some other kind of vascular issue, or that I'll relate to obesity. Is there anything about the endocrine system part of diabetes that would cause dementia or increase the risk for dementia?
That is a wonderful question, and I'm glad that you brought that up. When we typically when we see diabetes, we see that, you know, the patient has other comorbidities too, whether it's, you know, cholesterol or other things. So in my case, I have just seen how they all interact and how they all play a role in it. And so when looking at, I'm going to have to get back to you with that answer. And then maybe I can email Susan about that. But usually what I've seen in my practice, it's just because, you know, with diabetes, like it affects your brain too. It's not just the sugar levels that we're seeing, the physical changes in our body, but it also does end up causing damage to our brain. Mm-hmm.
Thank you. And then someone just made a comment, eating before bedtime is not good if one has any issues with acid reflux. And then there was a question about what is the average cost of testing?
Mm-hmm. So for a neuropsychological evaluation, that's if someone were to pay out of pocket, it would be $3,000 for that evaluation, and that would be for the clinical interview, for the testing, and for the report. report that we write and also the feedback session. If you have the insurances that I mentioned, then the insurance would go ahead and cover that, you know, and sometimes there is like a small copay that a person has to pay, but that's just based case by case. Every person has different types of insurance. So that's something that we could check with their individual insurance provider.
Okay, so I'll open it up. Other questions? Even though we're a small group, we have great questions. Anyone else have other questions? I'll ask. I'm part of the Alzheimer's prevention something where I get like every quarter I get like I have to do a little test, a cognitive test, and it has like 5 different things in it, and then there's like a subjective part too where you're talking about that. So what do you think that's worthwhile doing those kinds of things to just do
is it for like a research study or is it
yeah.
Wonderful. Yeah. So we were doing the same thing at the UC Davis Alzheimer's Disease Center where we would have people come in I believe it was every year, and we would do a full neuropsychological evaluation with them. And then we would also do like subjective things, like where we could ask them, like, have you noticed any problems in your memory, or ask, you know, a relative. And so that helps us because we get your baseline. We get how you're functioning. What if you started that study 5 years ago? We see what like your normal looks like. And over time, we're able to see those changes. And what we did at the Alzheimer's Disease Center is that if we saw a dip, you know, we would talk to you, we would tell you. And so, you know, that's good because we're able to track your progress. And even if someone wants to come get a neuropsychological evaluation, like, you know, they don't have to have an impairment, because it's good to know what your baseline is, because if you fall, we'll know what it is. And, you know, you're right. It might also help you kind of have that cognitive stimulation. So I don't know what questions are asking you, but I'm sure some are easy, some are hard, and, you know, it gets your brain thinking.
Yeah. All right.
I'm in a similar study with Women's Health Institute.
Oh, really?
But it's more related to sleep and memory.
Oh,
And so
interesting.
they did an original sleep study, and then they call me every 6 months and do a cognitive memory test.
Oh,
Just
wonderful. That's great. I'm glad to hear that, you know, they're doing that research with sleep as well. That's exciting.
I'd just like to say how wonderful it is that we have the UC Davis Alzheimer's Disease Center. I know University of San Francisco is doing important work, and we're just really lucky to be in an area that cares about this. I know one of your colleagues, Deborah Kahn-Weiner, I hope I'm pronouncing that, did a month-long class for Diablo Valley College.
Oh, yes, and I was also one of the speakers for
And
there.
you were one of the speakers, yes. And this community outreach and education and getting people thinking and talking about this is really, really important. And I am so thankful and appreciative of your talking with us.
Well, thank you. Thank you.
I have to say, my grandmother and mother both had Lewy body dementia. So I am fighting this with, you know, with all that I can. And I'm sure that other people are in similar situations and trying to be proactive. And one of the most important hopeful things is the phrase DNA is not necessarily destiny. So
exactly,
that's a keep doing all those good things, then we can protect our brains as much as possible.
And kind of looking at it from like a hopeful point of view. Now that you know the actionable steps that you need to take, and you know that you're going to work a little harder and you're going to take the steps to prevent that. So that's wonderful.
Kathy, I think you have a question or comment.
Yes, I was just wondering, you know, years ago, they came out with medications which slowed the progression of dementia, Alzheimer's in particular. And I was wondering if there's an average of 10 years between when Alzheimer's start and when you see the first symptoms. Does it make sense in high-risk families to start taking those types of medication earlier?
That's a good point. I don't know if there's any research on that, but what we do know with that medication is that it's not like something that's gonna bump up and improve your brain. So let's say if someone gets prescribed a medication when they have the disease, what we know is that that medication just turns back the clock 6 months and kind of keeps it around there. It doesn't really help with controlling the actual cause or preventing the actual cause. It kind of just really slows it down. And so it's not really like a magic pill that's going to get rid of it, but like we just see it as it slows down the clock like 6 months. And that's kind of where we're at. I'm sure you guys heard of like a new medication that came out recently. And so I believe it's aducanumab, and there's still like a lot of controversy around that. And I'm on a bunch of listservs, and it seems like people are just kind of going back and forth on that. So even though it's new and it just came out, there's still a lot of controversy with that medication.
Was it something that was used for cancer therapy? And this is an off-label use, is that?
No, this one's a little bit different. Like the FDA did approve it, but they're finding that that the advisory panel that put out that medication recommended that they didn't approve it, but they still went ahead. And so just because they found that it didn't have enough efficacy, but I think they're, especially with something so new, they're still going to be looking into it a little bit more.
Yeah, I did hear noted that it was the first one that had been approved in over 10 years.
Yes, that's the one. Mm-hmm.
So maybe that's part of it, feeling like there's a deficit out there.
Right, exactly.
All right. So Linda, I
think we're good. Thank you so much, Dr. Conde. I think we all had a very informative time with you. It was very interesting, and I like the interaction and everybody asking questions. As I said, we had 17 signed up for it, so sorry we didn't get that kind of turnout, but I think we had a small but interesting group of folks to ask questions.
Wonderful. Well, thank you so much. I really enjoyed being here with you guys and meeting you. And if you guys need me for anything, feel free to reach out. You guys have my information, okay?
So,
Thank you so
Dr.
much.
Conde, do you want to put up your slide with your contact information?
Yeah, let me go ahead and do
Into
that.
the recording. There you go. All right. Thank you.
Thank you.
Thank you.